Hello and welcome back to PTA 222, Patient Care Skills. Today we're going to focus on the ankle and knee, as well as clinical decision making for PT assistants. So when you get into class next time, there will be presentations for the hip and lumbar spine, since that was what we covered last week. I will answer any questions regarding this video on clinical decision making. And then we will review the case studies that are in this video for the ankle and knee. And then we'll get to the fun stuff, which is the lab, where we get to play around with exercises and practice our palpation skills. First, I want you to brainstorm. So pause the video and think about what are the components of clinical decision making? And then how do you know what treatments are appropriate for your patient? So how are you going to figure this out? Go ahead and pause the video and think about that for a moment. So the definition of clinical decision making would be the integration of the following: patient status. So the integration of patient status, which is their injury, their current level of function, their cognitive ability, their emotional state, their goals, their expectations. We're going to integrate that with the task at hand, which would be the exercise, any functional activity that you're having them do, or a manual intervention that you are going to use on them. And then you're integrating that with the setting you're in. So you got to look at your available resources, the equipment that you have on hand, and the staff that you have available if you need extra help, and how much time you have. So if you don't have a whole lot of time, then you're probably not going to do the most complex treatment because you don't have time. It might not be a safe decision to make. Where do you start? How do you know what to do with your patient? You're always going to start back at the initial evaluation. So look at their mechanism of injury, look at the pertinent medical history, and keep an eye on what their pain levels are. You're going to look at the objective findings and see how they relate to the function and the functional deficits. Look at the goals of physical therapy. Are they a low-level patient or are they a higher-level patient? So you might feel like those lower-level patients are really hard for you to figure out what to do with. Or conversely, you might feel like the low-level patients are pretty straightforward because they're so low-level that you have a feel for how you can advance them for function. But then you get a really high-level patient and you may be at a loss for, good Lord, how do I provide you with something more complex? And my favorite anecdote on that is when I always used to joke with my patients that, well, at least you're not auditioning for Cirque du Soleil. And that would be the little joke insinuating that, yeah, you have a lot of things working on, but at least we don't have to get you to do backflips. And so that was a great and funny joke until I had a patient who, as I was getting their mechanism of injury, I finally looked at him and said, "What do you do for a living?" And he said, "I'm an acrobat for the Cirque du Soleil," which was really intimidating because now I'm thinking, how I can't do a backflip. How do I educate this person on how to safely do a backflip and not hurt his ankle again? So you're going to look at the goals of therapy and look at how they relate to the patient's current functional status. And then look at the treatment plan. Have they had surgery? Is there a protocol? You might have all your clinical decision making might be pretty straightforward because if you're working with a surgical protocol, you have a list of things that you are allowed to do, and everything else is off the table unless you clear it with the primary PT. Let's think about the components of physical function. What do we mean when we're talking about physical function and what is involved in this? So if physical function is going to take into all these things into consideration. So we have our balance and our postural equilibrium. We have our cardiopulmonary endurance, which When you're already at the level that you currently function, you don't really consider, it's hard for you to understand that cardiopulmonary endurance may be a big issue until you yourself have had issues with your cardiopulmonary system, or you've encountered someone who has issues with their cardiopulmonary system. So that's a big component, and it's something that a lot of us take for granted. We also take neuromuscular control and coordination for granted. Unless you've had some neuromuscular insult, you don't really have an appreciation for how much we do is really tightly controlled neuromuscular and through the neuromuscular system, and our coordination is really how we function. The fact that we can coordinate our body parts to get a task done is actually pretty amazing. Of course, we're looking at mobility and flexibility of our joints. We're looking at the muscle performance, so that strength and endurance of our muscles and stability of our joints. So when we're putting this all together, there's some things that we just can we that can make our decision-making process a little bit easier. If you're working with a patient whose manual muscle testing is somewhere between a 0 and a 2, then you may be doing neuromuscular NMES. So to actually like facilitate that muscle with electricity with an NMES unit. And then you can progress to isometric contractions. Or you may start them with isometric contraction where you're just getting them to activate. So muscle setting, quad sets, glute sets, whatever muscle, that's not always possible to just magically contract a muscle under your volitional will. And so if you think about, your levator scapula muscle, can you just activate that levator scapula? Just contract it. Maybe you can just contract your biceps, but not all of our muscles are really easily accessible under volitional control just to do a setting or an isometric contraction. Sometimes we have to facilitate that isometric contraction. So if you think about placing a patient in front of a wall with their elbow bent to 90 degrees and you say, okay, I want you to just gently push into this wall. Then you're doing an isometric contraction in the shoulder, and you're giving them somewhere to go with it. Push out into my hand is a good way of facilitating getting a muscle to contract that might not otherwise be easily contracted willingly. Now, if their manual muscle test on the initial evaluation was beyond a 3, then we can start looking about doing open chain versus closed chain exercises. If they're at a 2 plus, are you going to give them a hand weight? If they can't actually lift their limb against gravity, resistance is lifting that limb against gravity. So when we're at a 3, we want to make sure that before we give them resistance, that they are capable of handling that resistance. So in the arm, the upper extremity, we're talking maybe a pound, maybe. You want to see what that looks like, what their active range of motion looks like, the quality of that active range of motion before you start adding resistance, or else you're going to see a lot of compensation really fast. Now, if range of motion is limited because of muscle tightness, then you can stretch the muscle and provide them stretching. You might stretch them. You might have them stretch at home. It might be an exercise they do in the clinic. If it's limited due to joint stiffness, then you want to do mobilization of the joint. So that's going to be a manual therapy technique. You might also have them do some kind of stretching at home that's more specific to joint positioning than it is muscle stretching. Or you might combine, do this joint positioning here, but then I also want you make sure you're stretching this muscle. So if your knee is stuck in, if the joint is stiff and doesn't allow full knee extension, then you want to be stretching the gastroc and the hamstring. Both of those muscles cross the knee joint, in addition to putting the position in a position of success, meaning don't rest with a pillow under the knee, because that's just going to contribute to this joint stiffness that is already limiting the ability to extend the knee. If it's limited due to pain, if the range of motion is limited because of pain, then you've got to do something to reduce that pain. So it may be a manual therapy technique, soft tissue mobilization, grade 1 joint mobilization, or maybe some modality to help reduce pain. If you're looking at quality of movement, we're looking at joint alignment and compensatory patterns. So again, when you're deciding what to do with your patient, if you're seeing that the joint alignment, say that they have a valgus collapse when they do a squat, you're not going to then give them squats as an exercise. Not necessarily. You got to work on that alignment. You got to work on their ability to understand what that alignment looks like and how they can avoid having that valgus collapse when they're doing their squat. So a lot of education, it may be manual cueing, it may be a completely different exercise first before you have them do squats. And then you have to consider how all this relates to what the patient is reporting. So again, if they have a 9 out of 10 pain, it doesn't really matter what their manual muscle test looks like, because they're probably not going to be doing a lot of active motion. You may look at some passive motion to help, gently mobilize an area. Or you might be working at maybe the joint below or the joint above to kind of get the focus, or maybe the contralateral limb. Again, maybe getting the focus off of that super heightened pain area and getting the brain to focus on something a little bit less painful. Considerations for the ankle and the knee. Remember, the knee alignment influences and is influenced by ankle alignment, and will influence hip alignment and lumbar alignment as well. Joint instability can cause muscles to overwork, especially in the ankle. Joint stiffness can restrict muscle efficiency. So if there's a very stiff joint, you can't dorsiflex because the joints are too stiff, then you're not going to get full mobility and full ability to utilize your dorsiflexing muscles. So they're going to get weak. So they need to be strengthened. It's hard to strengthen if you don't have a range to go through. So again, here are our YouTube links to several muscles in the lower extremity, as well as promised, our PhysioU video links as well. So there are bony palpations, soft tissue palpation, and looking for nerve entrapment sites as well for the knee. And then looking at the ankle and foot, bony palpation, soft tissue palpation, nerve entrapment areas, and kind of going back into looking at the skeleton specifically. And you can use the skeleton in class to compare notes on that as well. I do like the idea of drawing. So if you have, a henna drawing kit, then maybe you can draw in your metatarsals and your other tarsal bones, and then you can see them while you're working. But don't use a Sharpie. Be smart about it. Okay. Soft tissue considerations. I want you to also consider that for edema reduction, you want to elevate the limb. Be aware that when someone has a lot of edema, especially if they have pitting edema, you want to be careful about pressing too hard into that tissue. So generally, the tissue that fluid is in the interstitial tissue rather. So you're not going to be pressing deep like you're pressing into a muscle. You start proximal and you work towards you start proximal to kind of get fluid to flow, go down distally, and then work back to the proximal area. Thinking about where that fluid would be draining. So if you're aware of the where the lymph vessels are flowing, if we're working on the ankle, we're trying to get that fluid to go towards the back of the knee where the lymph glands are. And then from there, we're trying to get that fluid to go from to the groin where those lymph glands are. So If you're working on someone's ankle, though, don't just start massaging their groin. They will not understand what's happening, and you will get yourself in a load of trouble. Um, but definitely educate them as far as I'm going to do a little bit of light massage behind your knee and elevate your legs so that some of this extra fluid can go flowing back towards your heart. They'll understand that. You can tell and you can educate them. There are lymph glands behind the knee, and we'd like that fluid to go towards that area and then eventually go back up towards the heart. Do not attempt deep tissue pressure on an edematous area. It's going to be too painful, and it actually can close off the lymph vessels, and so that's not going to serve your purposes. Alert the primary PT if you see redness or discolored skin on the lower leg, typically the calf, especially if it is warm to touch. This may be a sign of DVT. So definitely let the primary PT know about that. When you're palpating around the fibular head, watch out for the peroneal nerve. You don't want to be pressing down on that. They won't like you. And then for your patients who have Achilles or patellar tendinopathies, transverse friction massage is a good strategy in addition to eccentric loading and isometric loading. Here are some basic ankle range of motion exercises. Ankle pumps when the leg is elevated can also help reduce edema. Gastroc and soleus stretch. Remember, with the knee straight, you're going to bias the gastroc. Just like up in here, when you bend the knee, you take the gastroc out and you focus the stretch down on the soleus. Ankle alphabet is a good way of just working on general mobility of the ankle. Ankle strengthening exercises. Now we're progressing a bit here. We have toe curls for the intrinsic muscles in the foot. The short foot stance or arch lift is another good one for both the intrinsic muscles and some of the supinating muscles. Then we have our band resisted inversion eversion, plantar flexion, and dorsiflexion. Moving up, now we do closed chain activities, which is also weight bearing activities. So again, choose these exercises wisely for your patient. Working on balance. So a narrow base of support, like either the feet together or in a tandem stance, can be a good way of working on balance. You can progress that to single leg stance on the floor, or versus being on like a cushion or the Bosu. The single leg, now we're going to get a more advanced. We're going to add a ball toss to this. And now they got to move their upper extremities. Maybe you have them do upper extremity before you have them do ball toss, and make sure that, again, pick your patients wisely. Not all people are great at catching a ball. So you could put them in harm's way if you're having them catch a ball when that's not something they would normally be able to do. So just be aware of that. I had a patient who was a theater major, and I had her do single leg stance, and she was throwing the ball at a kind of inverted inverted trampoline. There's a name for this, and I can't remember. But you throw the ball at the trampoline, and it bounces back to you, so you can kind of toss it back and forth. She was not a ball catchy, tossy kind of person, and it was almost catastrophic because the ball, of course, went off in a completely different direction. And thank goodness I was standing right there when she lost her balance, and I realized probably this is not in her wheelhouse. I need to find something that she's going to feel a little bit more successful with and not put everybody else at risk. We can get more creative by doing a single leg ball toss with a touchdown. So now they're touching the football down to different cones. That also makes them do kind of a single leg deadlift kind of motion at the hip and the knee. You've got the center of gravity changing immensely with the head and the trunk coming forward. So that requires a lot of skill. Again, higher level. BAPS board, if they're sitting, we're going back to lower level here, just working on range of motion. Single leg clock, touching the points of the clock is going to be working on balance and stability as well. Range of motion interventions for the knee. We're looking at passive and active assisted range of motion here. Working on knee extension, like I said, you can, put the joint in a position for extension for a prolonged period. I don't love this guy's back on this, so hopefully, he might be slumped because he may have some neural tension. So just be aware of their symptoms and their positioning when they're doing these stretches. Now we're looking at quad stretch or quad strengthening. So we start with our isometrics, our quad sets, pushing the knee down, getting the kneecap to move superiorly ever so slightly to set that kneecap in place. Really seeing a quad contraction. Sometimes you'll be tapping on the muscle to help facilitate their awareness of where that muscle is, especially if they're immediately post-op and can't generate a good contraction. Then you move up to short arc quad, to long arc quad. Straight leg raise really requires that they keep that knee straight. So it's different than a long arc quad because they're actually lifting now at the hip and they have to maintain knee extension. If there's a lag or the heel starts dropping down compared to the knee, they're not ready for that exercise. And this is another way of doing a quad set without anything behind the knee. Terminal knee extension with a TheraBand versus pushing into a ball. Moving on to different squat variations and forward lunge. Other examples are single leg squat, step up and down will make the knee and ankle go through that same range of motion, and school scoots and pushes. Be aware if you have your patient sitting on a stool and pulling themselves across the room, choose your patients wisely. Some patients are not capable of understanding how quickly to do that and could tilt the stool or tip it. Make sure your stool is in good working order, that the wheels don't get stuck, because I've seen patients fall and I myself have fallen off a stool. It's not fun. Hamstring curl, bridging. Here's that stool scoot or pull rather. The Russian deadlift or reverse deadlift, really using that hamstring and glute on the standing leg for helping to control the body, this weight here. Prone hamstring curls, standing hamstring curls. You can add a brace or a weight or a band to that. Uphill walking is another good one, making the treadmill at a high level and having your patient walk up that hill is another good way of getting those hamstrings and glutes working. Additional ankle, knee, hip exercises. Now we're combining our exercises. Foam rolls, we talked about that last time. I want you to, again, consider which exercises look like they are beginner. I mentioned that a lot in today's lecture, so it shouldn't be a surprise. Which looks more advanced and why, and can you list and match 3 exercises that look like they'd be a logical progression? We will review these case studies in class. And have a great day.